Sawade, thank you so much for the invitation. I wish I was there in person, perhaps sometime in the future, but I really appreciate the opportunity to speak with you all today. I will begin my presentation. So I'll start with hopefully many of you in the audience are clinicians. And so we always think about the patients presenting. And so here's an example for the first case where we have a 26-year-old woman with HIV. She's 10 weeks pregnant and she presents with vaginal bleeding and abdominal pain. And notably, at her history, she was actually diagnosed with pulmonary tuberculosis at 6 weeks of pregnancy and started on TB treatment. However, unfortunately, she lost her pregnancy because there were signs of gestational failure. This is another published case report in the literature of a 26-year-old woman who has gestational diabetes and a positive skin test and has 4 months of cough. And she had no chest x-ray done until after delivery due to fear of radiation exposure, resulting in a delay of her diagnosis. And by the time she got diagnosed, she had dissemination of TB to her eye, causing severe optic nerve atrophy and uveitis. And her baby had to be separated from her, be formula fed, and was given preventive therapy. And then we have a case here of that was published a few years ago of highly drug-resistant TB in a pregnant woman who was diagnosed initially with multi-drug resistant TB, that's resistance to isoniazid and rifampin. And she was diagnosed in the Republic of Georgia. And then over a 2-year period, she developed extremely drug-resistant TB, and part of this had to do with incomplete treatment courses that were with multiple drugs that are listed here. She eventually became pregnant, and at the time she was pregnant did not have any treatment, and she ended up seeking care in France. And there she presented with cavitary lung lesions and weight loss, and was at the time had no fetal abnormalities. But she had extensively resistant TB, requiring a special regimen containing a new drug called bedaquiline and linezolid. She was also given PAS, cycloserine, and levofloxacin. She ended up, thankfully, delivering a healthy baby, and there was no evidence of TB transmission to her baby, either through the placenta or when the baby was born. And she again was separated from her baby until she was smear negative. She ended up treating for 2 years, and her baby was well at 2 years as well. So these are some example of cases that you might confront. Now, I'll ask the question, what is the burden of tuberculosis in pregnancy? So the latest estimates of tuberculosis, new cases occurring in 2022 was 10.6 million cases, of which 3.4 million occurred among women. And the issue is we actually don't know how many cases occurred among pregnant women. And that's because we know it's likely to be high, but there's no routine reporting in most of the world's surveillance systems. So on the case report form that goes to the national TB registries, whether a woman is pregnant or not, or breastfeeding or not, is not recorded. So we don't actually have numbers. But what we do know is that TB incidence peaks during reproductive age. So on the top graph here, you can see that women from sub-Saharan Africa, and this represents 7 different countries, that all the peak incidence is around the ages of 25 to 44. And similarly, in a low HIV burden area of India, you can see that the peak incidence among women is between 20 and 30 years of age. This is also similarly observed in low burden TB countries such as the United States, where you see the blue bars are the female bars, and the incidence peaks between those 25 to 44 years. Now, thinking about screening and detecting active TB, specifically in pregnant women who live in high burden settings, these are data from several different screening studies. And you can see here that TB prevalence in pregnant persons ranged from 0.6 to 11% of pregnancies. Now, the 11% are outliers. These are these studies here. because these were screening done for active TB among those who had already an existing positive latent TB test. Whereas if you take all comers coming into antenatal clinics in high burden countries, the range is anywhere from 0.5 to 2%. So clearly, if you look for it, you may find it. And keep in mind, many of these studies were done before full antiretroviral therapy has been rolled out. And so some of those prevalence estimates have now come down in those living with HIV because of high penetration of antiretroviral therapy. Another effort to try to actually estimate how many cases of TB occur in pregnancy was done by this group, which looked at those TB cases, notifications, pregnancies, and age distribution, and estimated over 200,000 cases occurred each year, with most of these cases occurring in the African region and the Southeast Asia region. More recently, a group has tried to look at these estimates and actually found that more of the cases occur in pregnancy and postpartum, and it's important to take a look at both during pregnancy as well as right after delivery. And we'll say a little bit more about that. But again, data on pregnancy are not routinely collected, and so we don't have actual numbers. So we need to improve. Now, what about the state of pregnancy? Does that increase the risk of getting TB or reactivating disease, or can it be more severe during pregnancy? Well, we do know that changes in pregnancy are biologically significant, and here shown from a New England Journal paper summarizing some of the immune changes of pregnancy, you can see increases in things like innate immune cells, monocytes, phagocytes, the alpha defensins, and then you have a reduction in cellular immunity with CD4 T cells and CD8 cells decreasing, for example. And these rapidly rebound after delivery. Now, this has manifests as a few different ways. Actually, interestingly enough, for non-infectious diseases, you can have some improvements of autoimmune diseases like multiple sclerosis or rheumatoid arthritis, which then can flare in the postpartum. Whereas with lupus, you can have more aggravation. Whereas with diseases like malaria, you have an increased risk of acquisition of malaria and listeria, and more severity of malaria and viruses. We now know influenza and even COVID. We've recently seen that COVID during pregnancy can be more severe, as are other viruses. With respect to TB, however, the data are mixed. There's certainly an increased risk of developing TB, particularly in the postpartum period. But in terms of severity, it's unclear whether the disease is more severe or not. There's often delays in diagnosis, but the sort of wealth of data to really say whether it's a more severe disease has not clearly been shown. So we do know the majority of cases, as shown in these three studies, do occur, interestingly enough, in the postpartum period. And it's likely that the immune changes of pregnancy, where there's more cellular immunosuppression, leads to reactivation or acquisition, and then these symptoms manifest more significantly after delivery when there's a rebound in the immune system. Now, this is a systematic review looking at this question of risk of developing TB during pregnancy. And they took multiple studies, mostly from low burden countries, although there were a few studies from high burden countries. And during the state of pregnancy before delivery, it appears that the incidence rate ratio of those developing TB during pregnancy compared to not being pregnant is actually reduced. Whereas the increased risk is during the early postpartum, where there's an almost 1.7-fold increased risk of developing TB in the postpartum period. Again, mimicking likely fact that you have some relative immune suppression during pregnancy, but the actual symptoms and case detection occurs after delivery. And so why that's important is because when you think about antenatal care and following women, often you're paying really close attention to them and during pregnancy, but they often leave the clinic and you may not see them for some time in the postpartum period. So you want to educate women for symptoms that develop, particularly after delivery, and be on the lookout if they're at higher risk for developing TB. Now, I'll say a few things about the impact of TB on maternal infant outcomes. And we know that maternal to child transmission can occur, though it's relatively uncommon. So you can have a method of transmitting tuberculosis when mom has active disease. It can happen during in utero when there's hematogenous dissemination via the umbilical cord or the aspiration ingestion of infected amniotic fluid. It can happen during delivery when there's aspiration or ingestion of infected amniotic fluid or genital secretions, and then during the postpartum period when there's inhalation of respiratory droplets from mom or rarely ingestion of infected breast milk. So in terms of actual outcomes of what happens when pregnant persons develop tuberculosis, this was a study, a meta-analysis looking at 3,384 pregnancies that were active TB compared to 119,000 without TB. And you can see that pregnant persons had a 4-fold increase in mortality, 10-fold increase in hospitalization, as well as a high increase of 9-fold increase in miscarriage as some examples of adverse maternal outcomes. Now, comparing perinatal outcomes in the same study, you can also see that there were several adverse perinatal outcomes among women who developed TB during pregnancy. There was perinatal death was 4-fold increased, 2-fold increase of preterm birth, and a 5-fold increase in birth asphyxia, as well as a 2-fold increase in low birth weight. So clearly we need to do early detection of TB during pregnancy and treat TB aggressively so that we can try to modify these adverse outcomes. The next question that comes up is, does pregnancy impact the performance of our screening tools for active or latent tuberculosis? So you've heard about some of the wonderful data that Frank Koblenz just presented on screening. And I wanted to first say that as contrary to sort of concerns that many people who don't routinely treat pregnant women, is that you can safely administer a chest X-ray, especially if you must use a lead sort of cover to protect the pregnant person, but you can safely do a CT a chest X-ray. If you see here on this chart here at the bottom, very, very minimal exposure of radiation, and it's deemed safe, and it's not been associated with any harmful effect. So I wanted to make sure that we don't avoid doing a chest X-ray on a pregnant woman just because we're fear of some radiation exposure to her fetus. Now, in terms of thinking of symptom screening, you heard about the 4-symptom screen, which is cough, fever, night sweats, and weight loss. How well does this perform in pregnant persons? Well, this figure here shows that persons living with HIV, this WHO recommended 4-symptom screen has a sensitivity of 79% and a specificity of about 50%. This is when you look in pregnant persons, however, and this was based on several studies, screening studies done, you can see that this symptom screen has a much reduced sensitivity of only 22%, but a higher specificity. So in other words, these symptoms are insufficiently sensitive to rule in and certainly rule out TB. So you want to think about other things like asking about exposure to tuberculosis in the household or the workplace, ask about other potential signs or symptoms of extrapulmonary TB, such as lymph node swellings, because extrapulmonary TB can be more prevalent in pregnant persons. But you do also want to look for other tests, and we're going to need better ways of detecting TB in pregnant persons than just simply using the WHO screen. This is an area for clearly an argument for including pregnant persons in all the different screening studies so we can really look to see what works best. Now, changing our attention to latent TB infection screening, using tests things like tuberculin skin test or the interferon gamma release assay, which are the two main types of latent TB infection screening tests. The goal for use of these tests is to try to identify those who are at highest risk for reactivation of disease and to target our preventive therapy strategies. In the real world, these two tests leave a lot to be desired, and you heard about their poor predictive value of 2 to 4%, but there's also implementation challenges because both require, the TST needs two visits, you have to have the right type of subcutaneous or rather intradermal placement. And then with the IGRAs, you need a blood test and have to have a lab that can actually manage to test appropriately in the right lab conditions. But more importantly, also for pregnancy, we don't have that much data that have specifically looked at the performance of these tests. But we do know that, interestingly enough, we find that in low incidence settings, IGRA positivity is lower than TST when you do a head-to-head comparison in the same individuals. So more of the time you'll find an IGRA test being positive than a tuberculin skin test. Interestingly, though, the opposite is noted in high incidence settings, where the IGRA positivity is more or less is higher than the TST positivity. And this may be a scenario where the IGRA is more sensitive to recent infection compared to the tuberculin skin test, which may be a more memory T cell response that lasts for a long time, or could be a remnant of BCG vaccine. We do know that IGRA tests, as well as positive tuberculin skin tests, do predict, although poorly, the risk of developing active TB. Now, in terms of looking at pregnant women and whether these tests, which are both immune-based tests, are affected by the immune changes of pregnancy. And in fact, there are data that show that when you use these tests, do impact the rates of positivity. So here you can see you have during pregnancy and during delivery, a relatively lower level, but in the postpartum, the proportion that are positive is higher. And these are the same women that are followed serially during their pregnancy and to postpartum. And then when you look at their actual TB antigen responses and their mitogen responses, you can see that this is during pregnancy, this is delivery when it's the lowest, and then it goes up in the postpartum period. So again, when you administer these tests, when you're doing it during pregnancy, delivery, or postpartum, will affect your results. And now I'm going to speak a little bit about treatment and prevention with a focus on thinking about persons living with HIV. So when you look at drug metabolism and pregnancy, there are certainly a lot of physiologic and other changes that can impact drug metabolism, safety, and efficacy, and they're listed here. And some of these changes may, in fact, impact the response to TB treatment. But I will say, and you'll see in a few minutes, that there's not a whole lot of data specific to pregnancy because a lot of pregnant persons are not included in TB studies. And HIV, of course, we think of most of the HIV studies have happened with the view of reducing transmission of pregnant women to their infants. But with TB studies, actually, very few pregnant women have been included in TB trials. So we're left with knowing very little about these drugs. And in fact, this is an old FDA categorization of pregnancy therapies, but Category C is where animal studies demonstrate a risk, but no human studies have been performed. And that's where many of the TB drugs fall in that category. And so here, if you look at first-line drugs, many of which have been around for decades, still we have INH and rifampin as Category C drugs, whereas ethambutol is a Category B, and PZA is also a Category C. And we still have some unknowns with respect to crossing the placenta and what kind of concentrations they have in breastfeeding. And in particular for PZA, a drug that's used commonly in our 4-drug TB treatment regimen, you can see that there's actually different guidance, and I'll show you what I mean by that. So here in this slide, these are the two different guidelines. One is for low burden countries, which recommend, if you're HIV negative, to avoid using PZA. Whereas if you're HIV positive, they recommend the use of PZA because of risk of potentially developing more resistance. And in high burden settings, the WHO here recommends the use of PZA regardless of whether you're HIV infected or not. And so it results in a difference in the CDC guidelines from the WHO guidelines because of a concern of PZA and lack of sufficient data in pregnant persons. Now, when it comes to treatment of MDR-TB in pregnancy, there are many different drugs, and I show you here in the red box, UD means undetermined. And undetermined means the lack of data specific to whether it crosses the placenta, whether it's got breastfeeding compatibility. And so this ultimately means that you sort of often are left with expert opinion of how best to use these regimens and drugs in pregnant persons. But in terms of how the broad sort of context is that WHO recommends individualized longer regimens containing at least 4 drugs with established safety profile and low teratogenic risk as the basis by which to use your selection of medications. Now I'll go through some of the new and repurposed drugs used for multi-drug resistant TB. And again, you can see that we need more data. Bedaquiline, which is a very important new drug and is being now increasingly used to really shorten TB treatment. We don't have a lot of data, but what we do know is that it has a very long half-life in the breast milk compartment. And we also know that there were, from the small study of 6 HIV positive pregnant women who were on antiretroviral therapy, there was some reduced lower exposures during the pregnancy and postpartum period compared to those without being pregnant. But these reduced exposures are of unclear clinical significance. So this drug has been used in pregnancy, and I'll say a little bit more about it shortly. Other drugs, such as the new drug protonamide, which was just shown to be part of a very promising regimen called BPAL, which is 3 drugs and can be used with or without moxifloxacin, which can shorten the TB drug regimen for MDR-TB down to 6 months. We still don't have any data whatsoever specific to pregnancy. So we have to wait before we can use that new regimen in pregnant persons and need that safety data before it's fully implemented. And similarly, other drugs such as linezolid, which are also important drugs in multi-drug resistant TB, have a lot of unknown questions about how much gets across the placenta and how much is in the breast milk. But we do know that there's no birth defects that result. And then similarly, other older drugs that are used in multi-drug resistant TB also have a lot of undetermined, but we do know that some of the drugs such as aminoglycosides should be avoided due to adverse effects such as hearing loss, and ethionamide due to congenital and CNS defects also ideally should be avoided in pregnancy. So I'll now just shift over to some recent data that were summarized, all the case reports of pregnant persons who had MDR-TB, and they looked at treatment outcomes of these persons. There's 275 pregnant persons from 10 studies, and they showed that most of the time, most women were treated with drug regimens that included PZA, cycloserine, fluoroquinolones, and protonamide. Some of the studies that showed use of linezolid was associated with a higher success rate, but other drugs, including the use of fluoroquinolones or lack thereof, didn't have a clear signal of benefit versus risk. But this was the first sort of really nicely done systematic review looking at all cases to try to understand pregnancy outcomes. And importantly, I'd like to always point out that the group, this review showed that you could actually result in treatment success at 72% of the time. And this is a very favorable response compared to the concern of using a lot of these drugs and showing that there can certainly be side effects, but you can achieve treatment success. And I just make that point that certainly we do see adverse effects in pregnant persons using these drugs, but many of these can be managed, and they include things like liver function abnormalities, kidney function abnormalities, and the like. But importantly, treatment success does occur, and it occurs in the majority of women who are treated with these multi-drug regimens. Now, of course, there are some side effects or adverse outcomes, but many of these are around sort of 1.5 to 2.5 times what we would observe in those without MDR-TB. So I think the authors in this case series reported, overall, not overall to support the use of these regimens and to not sort of defer treatment, if you will. Now, I'll end on a few points about preventive therapy in pregnancy. There are several regimens that can be considered. There's 4 months of rifampin that can be used. But of course, you have to think about drug-drug interactions, particularly antiretroviral therapy. Several of them have drug-drug interactions. There's the 6 months of isoniazid, which is a WHO recommended regimen, particularly for persons living with HIV. There's also the 3 months daily use of isoniazid with rifampin, which can be used. But again, the rifampin component can have some interactions with antiretroviral therapy. Most people are not recommending long-term use of isoniazid, though there are clinical trials that have shown benefit. But the implementation of this is impractical and is not something that really is being used with any regularity. And then there are 2 newer regimens that have been published and are recommended in guidelines, although the data specific to pregnancy is limited for the 3-HP regimen, and there's yet no data for the 1-HP regimen. The 3-HP regimen is isoniazid and rifapentine given for 3 months at a weekly basis. And this is a nice regimen cutting down the treatment time from 6 months to 3 months. And it can be used in pregnancy, though the data are based on only relatively small PK safety studies, but there was no significant concern observed. And then the 1-month IHP regimen is isoniazid and rifapentine for 1 month. This is a very exciting regimen. This was shown to be efficacious in 3,000 persons living with HIV and was as good as 9 months of INH in terms of reducing TB incidence. And so this regimen is one that we want to see being scaled up. However, it's never been tested in pregnant persons, and so it's not currently recommended until we have a little bit more safety data. Do keep in mind, though, the rifapentine component can interact with several antiviral regimens, and so you have to bear that in mind. And these are just data showing some of the information from the 3-HP regimen, and I'll just quickly, since I've already mentioned this, I'll just, in the interest of time, seeing the time, is that we are right now launching a study to compare 1 month of INH rifapentine and the 3 months of rifapentine INH in pregnant persons so that we can fill the gap to help really guidelines for persons living with HIV. And hopefully these short course regimens will be safe and can be readily used. We're expecting results of this in the next couple of years. And then there's several other studies looking at drug-resistant TB, drug-sensitive TB with the new drug regimens as well. And we're hoping to really understand the safety, efficacy, and pharmacokinetic data of these new drugs, because it's a very exciting time in TB. We now are looking at newer and better regimens that are shorter, safer, and all oral. And so we're really hoping to sort of have much more options for pregnant persons, both for prevention and for treatment. So I'll end by saying pregnant people are at increased risk for TB, and TB impacts maternal infant outcomes. The WHO 4-symptom screen for TB screening reduces the sensitivity in pregnancy. The latent TB diagnostics have reduced sensitivity during pregnancy. There's some difference in TB treatment guidance between high and low burden TB countries, notably things like PZA. And then better and better outcomes are occurring now with the shorter treatment regimens, but we need more evidence specific to pregnancy because many trials don't include pregnant persons.
So I just want to thank you for your attention and for all the women and children who are involved in our work.